fruits and vegetables, over 4 to 5 cups per day. So that equals about 8 or 9 servings a day. And you may be familiar with myplate.gov, which replaced my pyramid. Yes? And if you've seen that plate, half of that plate is fruits and vegetables, trying to emphasize that that should be the priority. Fish, you should consume and instruct your patients to consume fish, especially oily fish, twice weekly, ideally, minimum. So that would be like salmon, for example. Fiber, 30 grams daily from whole grain products. A lot of people say, oh, I have oatmeal every day. That's not enough. That usually gives you from 2 to 6 grams of fiber, depending on what you choose. Nuts, legumes, and seeds at least 4 times weekly. Almonds and walnuts, you should just, Dr. Oz has this thing, he always snacks on almonds or walnuts. This is why, it's like a good snack. Saturated fats, less than 7% of calories. Well, an average calorie diet for a woman would be around 2,000 calories. So if you tell people less than 7% of calories, they don't understand it. So if we do the math, it's about 14 grams, less than 14 grams of fat. Cholesterol should be under 150 milligrams per day. That's about the equivalent of an egg yolk today, less than that. Alcohol, this question always comes up. How much is recommended? Less than 1 drink per day for women. And how many for men? 2. That's not fair, is it? Less than 2 per men. So what does it mean? It's wine, 4 ounces. So oftentimes you go to a restaurant or a bar and you order a glass of wine and they ask you, would you like 6 ounces or 9 ounces, right? And the answer is, I want a half portion. I want 9. You want to say that, right? Especially with a better wine. So just keep in mind that most restaurants and bars serve 6 ounces is the smallest portion. We want less than 4 ounces of wine, so you might need to order half portions, and they will bring it 12 ounces of beer or 1.5 ounces of spirits. Sodium, this number keeps coming down, less than 1,500 milligrams per day. How much sodium is that? Less than, you tell your patient that, and they're like, well, what is that? So it's a teaspoon, less than a teaspoon of sodium a day. It's hard to achieve that, especially if any packaged product has around 500 milligrams. Even lean cuisines have 500, 600, 700 milligrams of sodium. So if you eat one of those, you think, oh great, I'm having a heart healthy diet. You're not, you're getting half your total sodium for the day. So we have to constantly be vigilant, and it's really a chore to go to the market these days, I have to say. You really have to spend some time looking at products to make sure that you're getting good nutrition. Okay, what about physical activity? What are the specific recs for women? Well, I went over them briefly. So minimum of 150 minutes a week. So if you can exercise 5 times a week, 5 30-minute sessions would do it. That's minimum though. Ideally, twice that much. So that's essentially an hour every day. Vigorous intensity, half that much. But it's better if you do a combination of moderate and vigorous. So that would be things like walking and then adding your little toddler circuits or your stepper and adding that little interval training, things like that. So you have a combination. And muscle strengthening is also recommended. So it's not really sufficient to just do aerobics. You really do need to add some muscle strengthening. What if you are overweight and trying to attain weight loss? Well, then it's 60 minutes a day minimum. And if you're obese, BMI over 30, then recommendations are an hour and a half of exercise at least every single day. So this just gives you an idea of how much physical activity we all need to get. And we know that as we get older, we eat more and move less. And we kind of need to change that balance and help our patients do that. Okay, next, we start to focus on the major risk factor interventions, and the cut points are tighter now than they were. I've alluded to them, but I wanted to just pull them out, especially since they relate to some of your goals. So under 120/80, that's ideal blood pressure. Lipids, LDL, under 100, recommended for all women, under 70 for high-risk women. So for a diabetic, you would recommend an LDL under 70, because remember, a diabetic is risk equivalent to high risk. And then focusing, of course, on diabetes with a goal A1C of under 7. Okay, if you can't get to that with therapeutic lifestyle changes, then of course we want to add preventive drug interventions. And there are several caveats about aspirin use in women. So one way to remember this is that aspirin helps to reduce first MI in men, helps to reduce stroke in women, just for prevention. We know that the Physicians' Health Study, for example, showed this, and now multiple studies have shown that aspirin helps reduce stroke in women. Who should you give, what other groups of women should you give aspirin to? High-risk women, all those in that high-risk category, should be on aspirin. I'm not talking about somebody that recently had a stent. I'm just talking about for prevention. Women over 65, they are in the high-risk group for stroke. So aspirin every day daily is recommended for those women. So any woman over age 65, easy baby aspirin every day, unless of course there are contraindications. What about the at-risk women? This is where you kind of weigh the risk and benefits. If there are contraindications or relative contraindications, say recent bleeding, recent hemorrhagic stroke, etc., then no. Otherwise, yes, baby aspirin is good, 81 milligrams. Healthy women, no. So women in the ideal risk category should not routinely be on aspirin, although the guidelines say that you can use a baby if you want to. But it's not routinely recommended. Women's vessels are smaller, they're more friable than those of men, and bleeding complications are higher.
Question.
Yeah.
This is about the prior slide and LDL goals. I thought in the absence of risk factors, it was okay to have higher goals, like 130 and 160.
Well, that's per ATP3, Adult Treatment Panel 3, which is now about 10 years old. They were published, I think, in 2002. So one thing about the women's prevention guidelines is they're updated every 2 to 3 years. So the goals and the cut points are much tighter than some of the national guidelines. In ATP3, you know, every year is like it's going to be updated, but it still hasn't been. So the cut points are tighter for women because we have data on women that sort of justify those.
But from what you're saying, I'm guessing that the guidelines for men should also be much higher.
Well, we don't have actually heart disease prevention guidelines for men. These are one of the only gender-based guidelines that I know. The only other one is the use of ACE inhibitor in African Americans. It's not ACE inhibitors, hydrolyzine and nitrogen instead of ACE inhibitors in African Americans. So I can't really say. I mean, you know, it's kind of the flip side of the coin. Up to now, we have been extrapolating for women based on data for men. Now, your question is, well, should we extrapolate data for women for men? We don't know. All that we know is that the two are different, the disease is different, the progression is different, the risk factors and the way that the relative impact is different. So I'm not sure that, you know, you can make that statement. I don't know. Yeah.
Just to clarify what you said, that national guidelines are on goals. What guidelines are these from?
These are national guidelines.
Oh, I'm sorry.
Yeah.
From American Heart Association?
These are from, American Heart Association and ACC, and they've been endorsed by about 32 other professional organizations. They're the ones that were published in Circulation last year, and that have been revised multiple times. Okay, so just a little bit more about aspirin. So it's estimated now that only about half the women that could benefit from aspirin are actually on aspirin. So we are under-prescribing a lot of medications for women, including a simple drug like aspirin. And the majority of the women that are getting aspirin aren't really getting it according to guidelines. So many women are on 325, they really shouldn't be. There are many, many women under the age of 65 that are on aspirin that perhaps shouldn't be if you come to an appropriate assessment. There are a lot of low-risk women that are on aspirin because I think just not knowing the guidelines and sort of extrapolating from where we know that it works for men and it's preventive. Yes, but, you know, women's vessels may be different. And then other preventive drug interventions, the sort of usual suspects, ACE inhibitors, angiotensin-converting enzyme inhibitors, should be prescribed to all women after an acute coronary event, all women with heart failure, all diabetics, they're high risk.
All diabetics of every age?
Yes, all diabetics of every age, although the guidelines are for adult women. So, and we have to also take into consideration that young diabetics of reproductive age have a relative complication base because of their teratogenicity. So, yes, but most of us will not use these inhibitors indiscriminately of reproductive age. ARBs, angiotensin receptor blockers, as an alternative to ACE in all women that are candidates for ACE. Aldosterone antagonists in all women that are on standard therapy for heart failure that have an ejection fraction of 40. And beta blockers in all women with advanced heart failure or cardiovascular disease, even if they have a normal ejection fraction, because their pleiotropic drugs have multiple cardioprotective effects. And all of these are underutilized in women. Now, there are some don'ts. There's some don't do's because the data shows either no benefit or harm. So I've already talked a little bit about menopausal hormone therapy. Should be started or continued for the purposes of heart disease prevention in women based on current guidelines, both hormone therapy and selective estrogen receptor modulators. Antioxidant supplements should not be used for cardiovascular disease prevention in women. That includes vitamin A, C, and E. Okay, I always wait because it's like the what? Yes.
So does that mean you would tell women not to take a multivitamin?
Multivite's fine, but supplements are not. So, you know, the women that are taking 1,000 milligrams of C every day because, well, why not? They should not be doing that. The women that are taking, you know, whatever, 1,000 units of E every day because why not? They should not be doing that. And the same with vitamin A. So supplements, no. Supplements. What happens is that we fail to recognize that these are antioxidants, right? But at higher doses, they're pro-oxidants. So, you know, they're drugs like anything else. So in a multivitamin, fine. The best way to get all these vitamins is through your diet. Exactly. That's the best way. So if women come to me and they're on high doses of beef, I have them stop. Okay, and then we've already talked about the routine use of aspirin in healthy or adult women who are under 65, and folate. I'm not talking about pregnant women, I'm just talking about for heart disease prevention. So these are in the don't, do not do, they are class 3 contraindicated. Okay, very briefly, how much time do I have? A few more minutes? Okay, very briefly, just a few inspirations from our research. I'm going to go through this quickly, most of it's published. So really the question is, well, do these interventions work? Are they effective in women, and should we be doing more? So I just want to give you just the highlights of our experience both at the national and local level. We've had 2 grants funded by Department of Health and Human Services, Office of Women's Health, U.S. government. One was to look at outcomes in model women's health programs. So this is care delivered in a women's health clinic. And the other was outcomes in national community organizations. So this is care delivered in a community setting, decentralized from the hospital. And then 2 local studies. One was to look at outcomes in African American women in our local community here in Sacramento. And then we are hoping to start a pilot to evaluate outcomes in Latina women in our local community. So let me start very briefly with the comprehensive heart care program in high-risk women. This was funded by DHHS, published 2 years ago in Journal of Health. So there were 6 U.S. women heart programs funded by DHHS, which all total enrolled over 1,300 women. These were all patients of a women's heart center. The goals were to improve women's knowledge about heart disease, reduce the risk factors, attain Healthy People 2010 goals, we didn't have 2020 yet, in the Model Women Heart programs. The intervention was a 6-month sort of pre-post comparison of an educational and healthcare intervention based on heart disease prevention guidelines for women. There were 5 components, which involved education, awareness, risk factor modification, screening, diagnosis, treatment, cardiac rehab, lifestyle modification, and then tracking and evaluating outcomes. Heart care utilized the 2007 guidelines. I think this is because the 2011 had not yet been published. So it was very comprehensive heart care. The measures included surveys of patients' knowledge, clinical variables for blood pressure, cholesterol, etc., Framingham risk score. At 6 months, we saw statistically significant improvements in almost everything: women's funded knowledge, their risk awareness, and their clinical parameters. They attained or exceeded over 90% of all the Healthy People 2010 cardiovascular objectives. And I'm not going to show you all the data. Here's just one slide for some of the cardiovascular outcomes, percent of all women knowing the heart attack signs and symptoms. The first bar is at baseline, the second bar is at the end of 6 months, and the third bar is Healthy People 2010 target. And I think you can see that pretty much for everything, women improved, and we met almost all of the Healthy People 2010 goals. The only bugaboo always is obesity, right? It's very, very hard to reduce weight. And even with the 6 months, very, very comprehensive, very aggressive women heart program, it was very hard to improve it. The second that I'm going to tell you about is our National Community Organization project, which was published in Journal of Cardiovascular Translational Research in 2009. There were 4 national research sites, UC Davis was one, that enrolled 1,052 women at 32 community sites all across the U.S. Most of the sites enrolled high-risk women. Our site in Davis enrolled all African-American women throughout the country. So I'm going to tell you a little bit about this. The goal here was similar: to reduce cardiovascular disease risk in women. The way that this was done was by implementing a preventive intervention delivered in community settings. And the community settings could include a faith-based site. Now, I could not get the paper published with the title faith-based in it. I had to remove it. But it did include faith-based sites, which is interesting in and of itself, and maybe we need to think about that, because for many communities, that is the center, not only of community, but of health education and health promotion. Right? But I had to remove the title. 8 reviewers looked at the paper, and the editor finally said, I don't know what the problem is, I want to publish it. My only suggestion was remove this different title. So I did, but we did use a lot of faith-based sites. This was a 4-month pre-post educational intervention, all high-risk women. And then on top of that, there was a 3-month maintenance. So DHHS wanted to know, is 4 months long enough to improve outcomes in women in community settings? And then will they maintain the gains? The program included 8 bi-weekly sessions, so they met twice a month for 4 months. And they were counseling sessions, basically educational sessions delivered by lay people. The program was designed by us, the curriculum was designed by us, and the whole thing was monitored by us, meaning the grantees, but the actual care and education was delivered by community women. And we targeted all the major risk factors, plus signs and symptoms of heart disease. And then 4 to 6 maintenance sessions over 3 more months. They themselves designed the maintenance sessions based on what they thought that they needed. They just simply needed to include certain things like the physical activity component that always has to be part of it. We use surveys, again, to assess their knowledge, medical screenings for the clinical markers, health behavior counseling, risk behavior modification, And this study looked at stage of change. We'll be able to move people from maybe a pre-contemplative stage to a contemplative stage, so move them along and kind of wanting to make a change continue. We showed significant improvements in 28 secondary outcomes, almost all of the secondary outcomes, but we could not show improvement in the primary outcomes, which were tough. Weight reduction and increases in physical activity.
What were the secondary outcomes?
I'll show you some of them. They related to knowledge and awareness, clinical factors, knowledge of healthy lifestyles, things like that. Knowing the symptoms of heart disease and stroke, knowing to call 911, all of that. This is just one data slide. This is baseline, the end of counseling, the end of maintenance. This is a percent of the participants. And the one I pulled out was the effects of the intervention on their knowledge of modification for risk factors. So what are effective strategies for modifying risk factors? Here are the ones that we looked at. And these were all statistically significant. So from baseline to end of counseling, there were statistically significant increases in participant knowledge of how to modify these risk factors. And that were maintained for the maintenance phase. So I would say, based on the results of both of these, that both comprehensive heart care is very effective in modifying outcomes in women, and decentralized care delivered in communities and faith-based settings. Very quickly, we then brought this locally, and through a grant funded by UC Davis, the Dean's Office, we studied the African American women that we had, using the group that we had enrolled for the national study, a different group of women, obviously, but the local contingency, in a 4-month pre-post community-based intervention where we were focusing on cardiometabolic risk and inflammatory markers. Could we use a preventive educational intervention to improve cardiometabolic parameters and reduce vascular inflammation? So that the methodology was very similar. They had 8 bi-weekly counseling sessions, signs and symptoms of heart disease and stroke, and heart healthy lifestyles. And we did a similar kind of assessment, except that this time we assessed for metabolic syndrome and inflammatory markers, looking at C-reactive protein, interleukin-12, and TNF-alpha. And this I'm writing up, so I'm not going to show you any data, but I'm just going to tell you so far what we found. We saw significant improvement in multiple outcomes, and what was really interesting to me was significant reduction in inflammatory burden for all of the inflammatory markers that we looked at that were statistically significant at 4 months, and a 60% reduction in participants that met the diagnostic criteria for metabolic syndrome, which I've never seen published. So community-based intervention can be very effective in even these harder endpoints. So just to summarize, most of this I have gone over. What are practical prevention strategies for women, for delivery teams, evaluation, including symptoms, obviously, labs, framing and risk assessment has to be included under depression screening for older women and for those who have been. And then implement the guidelines, avoid things that are not helpful, and educate. So I want to just finish with maybe just some topics of potential discussion. So the weight of the evidence really does show that the heart disease prevention guidelines work, they're effective, and our data and that from other groups has shown that they work not just theoretically, they work clinically, they work whether you're a model with a heart program, they work whether you're a community setting, a faith-based setting. But the problem is that they are not being implemented optimally, and many women still are suboptimally treated. So these are some of the questions that I thought might be interesting for us to talk about. What should be the priorities for addressing the barriers? I gave you a huge long list. Maybe there needs to be a priority there. Should we start with education? Do we need to start with higher risk groups? How do we determine who we should sort of target, next for helping us addressing these barriers. Should quality measures be based on implementation of the guidelines, right? I mean, that would be one way to try to get things accomplished. What gets paid for gets done. And then what strategies could optimize implementing the guidelines? I've shown you some examples where you can educate people and then they can become trainers and that works. What other strategies might be effective here? What ideas have come to mind during my presentation? So I'll finish with that and I look forward to the discussion.
Great.
Thank you.
Thank you, Dr. Villablanca. This is great. I appreciate this. This is a very nice direction. Thank you. So what we're going to do next, I know we have several pieces that we have on our agenda, but we actually wanted to do a brief discussion of some of the things that we offered last time in terms of our homework discussion. And I wanted to ask Joyce to start our discussion, and then once we finish this discussion, we're going to try to go back to these questions and get your input. So maybe we could just keep the slide up just as we're thinking about Joyce and Shantae are going to talk to us.
So I wonder if, before we go to Joyce, if there are any questions for Dr. Villablanca.
That's all right.
Yeah.
Okay.
Yeah.
Yes,
Maybe just-
good, yeah. Any questions?
One question here.
Okay. All right. So,
All right, yes, I'm happy to take questions.
Okay, I had the questions. It's more of a practical question. It seemed to me that there was a lot of evidence that patients feel that physicians aren't talking to them enough about the disease. Has there been any study on how long it would take a physician to go through this? I mean, most office visits being about 10 minutes. And I guess from the Senior Foundation perspective, we do a lot of physician education. And I don't like the idea of doing the education and saying, you need to do all of this when we realistically know this may take 15 or 20 minutes and the physician has 10 minutes. Have you ever timed this to see how long it
Yeah,
takes
that's an
you?
excellent question, and that comes up a lot, of course, because we're all pressed for time, and there are increasing pressures to see more patients with less time. So there are a couple of strategies there. The Heart Association has published the Living Guidelines for Women, which is a one-page summary of all of this, which you give to patients. So what I usually do is the Living Guidelines have the recommendations for diet and exercise, all the risk factors, the risk categories, and metabolic syndrome, and then all of the risk factor goals. So what I do is I go in the room with that, and I identify the risk category for the patient, and I tell them why. What are all the criteria? They're all listed. And then I go through whether they have metabolic syndrome or not, and what that means, and I just check or circle. Everything's listed on the page. It's called the Living Guidelines for Women, and you can just Google it. It'll come right out. It's in color. You can download it. It's double-sided. Then on the back side are all the major risk factors, the current goals, which are the ones that I just went over with the cut points, and then the patient's number. And so what I do is I just start with that, and I tell them this is a treatment plan. It will take some time to accomplish all of these, and then I just pick one or two that I think are priorities and start with those. And so the patient can see where you're going. They can see that you have a plan. They can see where you're going. And then I give them a folder, a red folder, with information from the Heart Truth Campaign and the Heart Association for them to look at and read. So you're right, you can't do all of it, and neither should it be your responsibility. I think patients need to be taught that they need to become partners in their care. I like to say the patient's not the problem. That they need to become partners in their care, and that the more educated they are, the better they will be able to have you help them, and that you're there to assist and to help them attain the goals. But it's not your problem. It's not really your job. It's your job with them. And so once people understand that, I find that they become much more engaged. And sometimes I walk in the room, we always measure people's ways. I walk in the room and the first thing the patient tells me is, did you notice that my waist is down 2 inches? So they become engaged, and this is, I think, one really important thing, and one very important strategy. And then, of course, using allied health professionals. You can't do it all, nor do you have all the knowledge and skills. So Sharon from Davis works with our preventive cardiology program, and I make very good use of preventive cardiology for exercise where we have the dietitians, the partner, whoever is doing the cooking and shopping needs to have the education for appropriate, not just cooking strategies, but for restaurants, what to pick up off the shelf. So using the allied health team, thinking of it more broadly than just you. And others here probably have other strategies that they use as well. But you're right, you can't do it in 10 minutes, and the patient needs to understand that they have to do some of it. They need to become educated, and you will help them, and it will take some time.
You had a question?
Oh, right, okay.
Is there any other questions?
Yes.
Yes, I was wondering, because there's a family history of heart disease, do you try to also treat the family? Let's say you're treating the mother, and there's 2 daughters. Do you try to, approach with the family of saying, let's say on the diet, saying, try to incorporate that with the whole family, or you just have to see each individual?
It depends. Sometimes people will come with their daughter or their mother or their sister or their best friend who needs help more than they do sometimes. So it depends. I look for opportunities. If those present themselves, then I'll say something like, well, and you can do this together. You might choose to come up with a plan together for walking or exercising or revamping family recipes or whatever it might be. Sometimes it's just the patient is just so overwhelming in terms of their problems that that's really all you should focus on. So I would say it depends. For me personally, it depends on the situation, but I look for opportunities to talk to them about the fact that a healthy woman is a healthy family, which I think is really true, and that many of the risk factors cluster in families because they relate to really kind of health behaviors that kind of are ingrained in families and developing families. And children too. I mean, obviously the diabetes epidemic in children, something's going on in the family, modeling and food choices for that child that are affecting them. And so I think it's very important to get at families, but sometimes you can't do it. There's just too much going on with the patient themselves.
Well, because diet's the one that's obvious.
Right. And exercise.
Right, because you might have resistance to getting separate diets, for example, for each member of the family. It might be one because of convenience or whatever. And so, just things like that. I could just see why it's really important to know what the whole family history is.
Right, and I think here's where a dietitian can really help because they typically will spend an hour with a patient that you've never had. And they can get at a lot of what's going on with the family dynamics, and the reports that they generate oftentimes really helping in terms of counseling patients and trying to, undermine in a way some of their reasons for not complying, giving them strategies for being able to adopt more healthy lifestyles. So I use it as ammunition, is what I'm saying.
Thank you. Great. I'm sure there are a bunch of more questions, and maybe at the end, if there is a little bit of time, Dr. Villablanca can spend with us. So let's move on with Joyce and, oh, by the way. Joyce.
Well, I'm a substitute today. I pull it up at a good thing. So in the last meeting, Dr. Agnihotri, who could not be with us today, he's back at the CMMI Innovations meeting of all the innovations advisors around the country. He worked with Dr. Arevalo and Mary Firmison to create some homework for all the medical groups to try to look at their data on blood pressure and lipids and just see specifically how are we doing in our own Sacramento region. And Mercy stepped up and has worked on their data and is willing to share their data and be an inspiration to the rest of us. Thank you, Joyce.
Exactly. So as Patty said, I'm here on behalf of Dr. Amparo. I'm Joyce Higley. I'm the director of the Heart and Vascular Services for the hospital side. So we collaborate closely with the medical group, and so it's exciting to see their results today. Prague would say he would encourage all of us to collect this population-based data. The agenda says I'm an RN, but I'm actually a registered dietitian by trade, hospital administrator by day. But it's certainly disease management and these types of programs I really do believe are going to be a way to really improve the community care. Personally, I'm excited to hear about the women's side of things. We have a couple of women's initiatives, and one of them I was going to mention is going out to physicians' offices, primary care, and training and certifying the physicians to be heart-caring physicians. Because we found that as we went out to the community women, that they were still not getting the feedback from their physicians that they wanted. So we thought we had to kind of do a dual approach on that education. So back to the data on hypertension. So Prague would want me to be able to share that the definition, percentage of patients for visits that are 18 years and older with a diagnosis of hypertension, with a blood pressure of greater than 140 over 190. And this would be documentation on 3 different occasions of the blood pressure. So just getting started with this challenge. So in August, the Mercy Medical Group, which is now Dignity Health Medical Group, saw a compliance of 69.8% and then